We are often confronted with impulsive, aggressive behavior of our patients, and this behavior seldom stands alone. It's often combined with emotional disorders and a broad range of self-destructive behaviors. And all these symptoms are showing a high intercorrelation, and it's always a question whether there's an underlying personality disorder like the borderline personality disorder. BPD is also an adolescent serious mental disorder with characteristic patterns, instability of affect, low impulse control, difficulties in interpersonal relationships, and we always, or nearly always, could find a disturbed self-image. And there's a broad range of clinical manifestation which ranges from self-destructive behavior until delinquency and aggressive behavior. And the self-harming behavior, I think, is the most prominent symptoms which leads in most cases to first treatment initiation. Why and why now studies in adolescent samples with BPD? And in comparison with studies in adults, there is a great delay of studies in this age group because of probably a late acceptance that the diagnosis of BPD can also reliably assessed like in adulthood. And if we have a look to previous studies and publication, you will find some studies on aggressive behavior and BPD in adults, but nearly no studies in adolescents with BPD, and especially there's no study in male adolescents. And I think that's a great advantage to do research in youth with BPD, because there you have a reduction of confounding factors due to a lower chronicity or effects of treatment. So our hope is that if we can define a typical risk constellation as well as biomarkers, then we can have an early identification which could lead to earlier specified therapeutic interventions. Here, for instance, a group of female adolescents with a diagnosis of BPD with a mean age around 15 years. There you can see that nearly all female adolescents fulfilled the self-harming criteria, and you know 5 of 9 criteria must be fulfilled to define a diagnosis of BPD, but also the criteria of impulsivity and affective instability, as well as loss of aims and aggression control is in most of the cases fulfilled. This is a typical profile of fulfilled diagnostic criteria in adolescents. In adults, it's similar, but you will find a lower degree of self-injurious behavior. And the disorder by itself is very heterogeneous. and it's more complicated also in treatment by the high amount of current axis 1 diagnosis. Here, for instance, you see a high amount of depressive disorders could be found in our sample, as well as eating disorders or anxiety disorders. So there's a high load of axis 1 disorders, as well as additional axis 2 disorders. We found mainly that about 40% of our adolescents also fulfilled diagnosis from the cluster C. So one of the major questions is how emotion dysregulation and impulsive aggression is interrelated or is based on several etiological factors. And the idea is, or the assumption is, that emotional dysregulation is the major point which leads to behavioral dysregulation, like self-destructive and aggressive behavior. And there are now some studies who showed evidence that there's a link between emotion dysregulation and autoaggressive behavior, but the mechanism which increases the risk of aggressive behavior is certainly understudied. And if you have a look to the previous studies, you will find it's mainly the phenotype of physical forms of aggression, which may be characteristic for males but not for females. And so Bunny argues that we have to look more for relational forms of aggression. And there's excellent review by the working group of Sabine Herpertz from the adult psychiatric department in Heidelberg. And she delineates that reactive aggression can be regarded as a consequence of affective dysregulation, impulsivity, threat hypersensitivity as measured by neuropsychological experiments, and she made the important distinction between affective empathy, which should be intact, and reduced cognitive empathy, which may be one factor which is open for therapeutic intervention, like the mentalized-based approach. And they summarized the model of reactive aggression in BPD in this figure. And if you have a look to the affective dysregulation, it could be related to, for instance, an enhanced reactivity of heart rate. And if you have a look to the brain imaging studies, the imbalance between prefrontal and limbic areas are very well known. And another point is the threat hypersensitivity. You can investigate in neuropsychological studies, and they also found an empathic deficit, but only in the cognitive empathy dimension, which could be related also to high vasopressin activation. Reduced self-identification could be found, and also could be related, for instance, for changes in the somatosensory cortex. And impulsivity is most well studied, where the findings could be linked to deficit in the central serotonergic system. And now there are coming out some studies in male BPD, and so this research group could found a volume loss of the ACC, a reduced serotonergic responsivity, and also functional as well as structural abnormalities of brain structures. And they also investigated the possible effect of testosterone, but they couldn't find any relation. But it's still important now also to compare a male BPD patient with female BPD patients. The studies are on the way and not already published. And Professor Fossati from Italy was one of the first who investigated the possible prediction of borderline and antisocial personality disorder features here in a great population-based study. And he could find that there's a common impulsivity dimension in the prediction of BPD and ASPD, but the aggressive facets were likely different. And now in a longitudinal study comparing this both personality disorders in a clinical sample, they could found an association between BPD symptoms and aggression was mediated uniquely by difficulties in regulating emotion behind trait impulsivity. And this is one of these very seldom studies in adolescent samples in a longitudinal study. And the idea was to measure whether differences in stress physiology may be linked to risk of aggressive behavior in youth with BPD. And in this study, they used a laboratory stressor and investigated several subtypes of aggressive behavior, and could found that when the physiological arousal was exaggerated, reactive aggression was heightened, and girls with BPD who exhibit heightened physiological reactivity to interpersonal stress were more engaged in relationally aggressive behavior. So if you have a look to different kinds of vulnerability, you have to have in mind on one side the social influences, on the other hand the possible biomarkers. And the idea is in this concept that the emotion dysregulation is fostered and maintained within an invalidating developmental context. And there's a poor impulse control and emotional sensitivity are early biological vulnerabilities. And these interrelation is difficult to investigate. And we also try to answer these research questions, and some of our studies I will present to you a little bit later. And Brunner and colleagues developed a model you can see here on the slides, and the idea is if there is a biological risk factor for impulsivity, and with this fact meet a high risk environment, it could lead to weak emotion regulation skills and resulted in behavioral symptoms which could be differentiated in boys as well and girls. And I'm not so very well convinced on this model, as we know that boys as well as girls can fulfill both personality disorders, BPD as well as SPD. And on the right, the protective environment could have the influence that no risk behavior will emerge in the long term. So how to study the vulnerability? There are many attempts to delineate the phenotype as well as possible new biological factors. And I agree very well with this model outlined by Putnam and Silk. We have to have in mind the primary etiological factors. We have to have a look to the developmental sequel and define the domains of dysregulation and the indicators which are also open for new biological oriented studies. So I would like now to present some data from our studies in Heidelberg. And for instance, here's some results when we were comparing a group of female adolescents with BPD with clinical controls as well as healthy controls. And I think it's always worthwhile to include a clinical control group, otherwise we cannot argue that our findings are specific for this group of patients. And this was the categorical assessment as well as the dimensional assessment. So we measured dissociative experiences as well as other forms of psychopathology, as well as temperamental factors. And here you can see the distribution of the scores with regard of the capacity of emotional regulation. So the BPD group was worse than the other two groups. Impulsivity was also very high in the group as in the BPD group as expected, but interesting, the clinical control group and healthy controls have nearly the same problem, as well as in anger control. And interestingly, we found a temperamental constellation which also have been found in adult samples. A high degree of novelty seeking and a high degree of harm avoidance. And if you have in mind the antisocial personality disorder, there you will expect also a high novelty seeking, but low harm avoidance. And so this is very typical in the disorder of BPD. And of course, which is characteristic for all personality disorders, difficulties in self-control. This study on temperament was based on the cloniter instrument, and the idea is this constellation of high novelty seeking and high harm avoidance reflects an approach avoidance conflict leading to the prominent affective instability. And the question is whether specific risks are in the biography to develop clinically manifest BPD. And another study from our group where we wanted to know whether the HPA axis is different to healthy controls, and we found a hyporesponsivity here indicated by a lower expression of cortisol within a stress induction paradigm, the so-called triasocial stress test, where the participants have to do a mock interview in an audience, and surprisingly they have also to fulfill a mathematic task, and you see both groups, the healthy controls as well as the BPD group, react from the autonomous nervous system very similar, but not with regard to the cortisol expression. And another study was whether there are difficulties in the emotional information processing. And the interesting finding was that there was only a difference between the adolescents with BPD with the other groups when they were currently in a state of negative mood. If they weren't in a negative mood, they interpreted the phases equal as the other groups. And so in other group from Melbourne, we cooperate, found very similar findings, and the idea is that the difficulties in disengaging attention from settling information is a vicious circle that lead to affect regulation and the typical behavioral outburst. So we think that these findings could lead to specific intervention strategies. And the other question we raised is, if we find difficulties in emotional information processing, are there also basic neurocognitive deficits and deficits which may reflect neural abnormalities in the prefrontal cortex, which were found in previous studies in brain imaging. And one major question was, is it a permanent or stress-dependent neurocognitive deficit? And these investigation is based on a model that stress may lead to an impairment of the central executive system, which may lead to the characteristical deficit in adolescence. As we know that people with BPD can behave very normally outside of stress, but aggravated their problems when they are under stress. And we found no impairment in working memory, and also no deficits in the higher executive function under a laboratory stressor, and which is very indifference, for instance, for adolescents with ADHD. But we found an attenuated heart rate response, which may contradict current theories of biological determined effective hyperresponsivity in BPD. And now I will give you a short insight, a short review to our brain imaging studies, which is based on the frontal limbic dysfunctional model in BPD. So idea is that the weakening of prefrontal inhibitory control may contribute to limbic hyperactivity, and the other way around, limbic hyperactivity may contribute to less cognitive control. And there were previous studies which could find reduced orbitofrontal volumes, which was already done in adult samples, but we couldn't find any changes in the limbic system. And here you can see the results of the psychometric measures. You see here the borderline patients reported much more depressive symptoms, anxiety, dissociative symptoms, and here the Barrett impulsivity scale, you see a high amount of impulsiveness. Here, the emotion control problems and the higher amount of traumatic experiences. And what we found is also a reduction or lower density in the left orbitofrontal cortex, which is in line with the findings in adult samples. But this finding was not specific because also the clinical control group demonstrated a lower density in the orbitofrontal area. And next to the microstructural approach, we did a study using the diffusion tensor imaging, which is be able to investigate structural and physical, the neural tissue, the fiber tracks, which are integrated or in the model of the emotional regulation network. So we investigated the cingulum, fornix, and uncus. So very important structures which are involved in emotion, motivation, and so on. And we found a reduction in the fornix of the fiber integrity, but no changes in the cingulum in the uncus. And we have a look to the white matter skeleton with the TBSS analytic technique. We found changes which are related to areas which are involved in emotion recognition. So to summarize this study, we could show changes in the fornix and also in long association bundles interconnecting the heteromodal association context. And based on these findings, we concluded that deficit in both emotion recognition as well as emotion regulation simultaneously may contribute to this disorder. So I like to sum up. There are many indicators about etiological factors with regard of environmental factors. There are indicators of biological vulnerability factors, so a decreased in prefrontal structure, changes in emotional, not in neutral, in emotional information processing, the first evidence for stress-related changes in new hormones and autonomous nervous system. And studies from other working groups could show that altered stress response system may be a crucial underpinning of reactive aggressive behavior, and there also the argument that there's no link between emotional dysregulation and proactive aggression, but we have to be careful because proactive aggression in BPD is certainly understudied. There's the questions whether these first studies in adolescents sample could have therapeutic implications. I think probably we need more integrative therapeutic approaches in which these four domains are targeted by different therapeutic approaches. And I think it could be a way to develop it for these specific subtype of BPD patients, a subtype with a prominent feature of reactive aggression. So further, what are the aims in the future? The relationship between autoaggressive and aggressive behavior in BPD are not addressed, surprisingly not expressed in research so far. I think early identification of this high-risk group of patients with BPD from the impulsive aggressive subtype is necessary to improve risk assessment and subsequent intervention. We should have a closer look to the neurobiological underpinnings of reactive aggression and go further on with differentiation between cognitive and affective empathy. And it would be very worthwhile if we could combine larger clinical groups with community-based groups and forensic-based samples. And of course, we should include male patients, especially of patients with BPD in younger ages, and we should not forget to include clinical control groups to answer the question of specificity, and we hope that based on all our findings we can delineate a more specific modified therapeutic intervention for this certain group of patients. Stummer wird und immer stummer ist